Good evening, everyone, and welcome to our week 3 of PRI Breathing Mechanics in COVID times. We appreciate all of the familiar faces that we keep seeing on a weekly basis here on our screen, and it's just so great to be able to connect with you guys, even during this time when we can't see you in person during courses. So thank you very much for joining us again tonight, and it should be another fun evening. Tonight we're going to be talking about balancing pleura cavity negative pressure through ground pressure. And tonight we are going to get into that technique that we have kind of been leading up to these past couple weeks in discussions. And we're actually going to go through that technique quite a bit tonight. And we may even have a chance for a couple questions here at the end because we don't have as many slides to get through tonight. But I will go ahead and turn it over to Ron to begin tonight's webinar.
Good evening, everybody. Jen, they have that technique.
That technique, that technique has been posted to our website. It was a couple weeks ago, but yeah, it's available free on our website. We linked to it in last week's handout, but I will put the technique on our webinars page tomorrow as well. I will link it directly on that page as well. But the handouts for tonight, I posted them about 2 o'clock this afternoon to the website. So if you had a chance to look at those or print those off, they are available on the webinar's website.
Topic this evening is one that has been on my mind since we decided to do these sessions, these webinar sessions, and that is balancing the pleura cavity that we have inside of our body. We've got a cavity within a cavity within a cavity. So we've got this thorax that's, Jen has all these muscles and bones kind of protecting us. This is really a shell of protection. That's really what this is. It's actually not a very good system for expansion. In fact, the purpose of this shell is to restrict us from blowing apart. This keeps us condensed. It keeps us supported, if you will, from things that are pressure activated. That would be atmospheric pressure on the outside and intrinsic pressure on the inside. So it's not a wonderful model for us to really use to expand. If anything, it's really there for us to be limited in expansion at these end ranges of movement and motion. Otherwise, we'd be all over the place. Our lungs aren't going to necessarily hold us up if we don't have something around them. So every time I look at this thing, Jan, I remind myself it's one of the most wonderful systems to limit us. So maybe we all just keep that in mind this evening. We have limitless activity when it comes to our pleura and our lungs, but we have limited activity as a result of this rib cage that has multiple layers that go from the outside into the inside. And you guys all know that, but I want to remind us this evening, we're going to try to balance that out by activities that are going to empower negative pressure, not positive pressure, but negative pressure, pressure that is voided or created to draw things out, to pull things out. That word pull can't be accomplished if you don't have something to pull from. And the only thing you have as a human to pull in air with negative pressure in a pleural cavity is the ground you're standing on or the ischial seats you're sitting on. That's the truth. If you didn't have the ischial seats or the ground, your ability to generate, pressure that you need to create from things that you're pushing on, you wouldn't be able to allow that chest wall to move and limit your activities of breathing. We limit our breathing with how we use the floor. We enable our breathing by how we use the floor. The people out there that can't get air in can get it in. They just don't know how to use the floor most of the time. Unless you have a thing called, chronic obstruction pulmonary disease or asthma or allergies, many of your patients can breathe. They wouldn't be in your office if they weren't. But they don't know how to breathe correctly because they don't have a good balance of their pleural cavity. And that's what we're going to talk about this evening. And you don't balance anything in life without a give and take relationship. And that relationship's got to have a ratio of activity on two sides. Otherwise, if you don't have something that's positive or with something that's negative, you don't have really any meaning. And if you don't have anything that's negative with something that's positive, i.e. something that's there for you at all times, the floor, the ability to push away from, so you can pull something to create negativity, you don't breathe. You don't, your system doesn't expand. It doesn't fill. So when I look at performance in life, when I look at what we're doing right now and with the patients we're working with or clients we're working with, whether they're sick or not, you can have a sick pleural syndrome if you don't have balanced pleural performance. Pleura performance is a regulatory activity done between pressure inside your chest wall, as we're going to find out tonight, and pressure underneath your feet that's going on at the very same time when you're up moving around. When you're in bed at night, that pressure is still there. You have something to move around with called ischial seats. And those ischial seats allow you to move your pelvic floor and your thorax and take your appendages with you because of the negative pressure that's being produced inside of you. If you didn't have the negative pressure inside of you, you wouldn't be able to roll from one side or the other. Your layers of activity would be too static. There'd be too much friction. You wouldn't be able to walk. And a lot of patients that you're working with these days can't walk and roll because of too much positive pressure inside of them, not enough negative pressure. So that's kind of an overview, Jen, of what we're going to talk about this evening. And anytime I talk about, even if I weren't on this webinar series, Jen, you know me, anytime I talk about pressure, anything in life, whether it's psychological pressure or physical pressure, or tonight it's all going to be physiological pressure, you can't talk about it without talking about the word ventilatory or ventilation. So you're going to read a lot of articles if you like this discussion tonight. There's lots of articles that you can look up that have NPV in them, which means negative pressure ventilatory activity, negative pressure ventilation. Start reading about those articles. You'll learn a lot. You'll learn a little bit more than I'm going to give you tonight. But that's what this really discussion is all about. And I've learned early in life that you can't talk about breathing if you don't have opposition for this negative pressure gradients. And that opposition, Jen, comes from, we were scampering around this afternoon or this morning finding our opposition muscles, abdomen. Got to have an abdominal wall. You're going to see that tonight. You got to have the ability to use your hamstrings, and you definitely have to have the ability to reinforce push from your glutes. So your abdominals, your glutes, and your hamstrings create negative pleural pressure. And negative pleural pressure creates good opposition push from those three muscles. Your category should say, what's synonymous with these three muscles? What's synonymous with glutes, abdominals, and hamstrings? And you would all say after this discussion tonight, negative pleural pressure. NPV, negative pleural ventilation. Because without those three muscles, you're more of a positive, internalized thinker and mover, which means you're inflated, which means you're stuck. Means you've already got too much air in you and you don't know how to get it out. That's an upcoming webinar. We're going to talk about hypercapnia down the road. But right now we're going to talk about MPV this evening. So we put this little handout together, and I assume, Jen, everybody has access to it. This week, I'd like to help you all understand how our feet help our ability to breathe. It's that simple. We're humans that breathe with our feet. We don't have gills in our feet, but we kind of do. We breathe with our feet more easily and effectively with both of our lungs working in a corresponding way with the diaphragm that's attached to those or around those lungs with central tendons. And you have two of them. You got a right one and you have a left one, as many of you know. This morning when I met with Jen, I said, Jen, I forgot a word. We added it. There it is. And pleura. We often forget about that concept of pleura. Two central tendons, two diaphragms, two lungs, two hemispheric rib cages, and two cavities called pleural cavities, which we're going to talk about. They all go into one, but they're hemispheric cavities. So please keep that in mind. Here's a good demo, a good illustration of your viscera pleura that lines your lungs and your parietal pleura that is on the outside of that pleura and is on the inside of your outer covering of your shell called the rib cage. And the visceral pleura and the parietal pleura then give you this wonderful cavity called the pleural cavity. Ambulatory activity, reaching activity is all done with pleural cavity movement. It's frictionless because it's pleura. We had more time this evening. I talk about pleura like I do diaphragms. Pleura is pretty big in terms of operative pressure management. And then on the inside of that visceral pleural, you've got your lungs. And the last time we met with Jen in this room, we talked about the trachea and the bronchioles, and we talked about ventilatory perfusion. You're looking at layers of activities, and in our PRI classes, we call those layers of activities zones of what? Zones of apposition. And Jen, you're so correct. And really, apposition started in that embryonic developmental period at the 5th week. You already had good pleura. It was moving around. That was a sac that was developing around a heart and your gut. Your gut was the first pleura you had. And in fact, without getting too digressed here, what you're looking at is really layers of pleura that were established by a system that has to regulate constant peristaltic movement underneath of it. So these layers all have opposition, and we're going to talk about its opposition for apposition, and that opposition comes from those three muscles for this negative pleural pressure that's going to be operative in that pleural cavity. When our diaphragms contract upon inhalation, our chest walls expand. And that's done through this mechanical pull. And if you have your handouts, just write down this or underline it. Pull. The diaphragm pulls as the feet push. If your diaphragm pushed as your feet push, you'd fall over. You'd pass out. You would get dizzy and lightheaded. You'd have persistent postural discord. There's actually a syndrome on that. Same type of activity. In other words, diaphragms were made to pull when there's something for them to pull off of. And you can't just pull everything in life. You would pull yourself to death, literally. So the muscle that pulls us is the diaphragm, but the muscle that secures us is the abdominal wall around that diaphragm that has to be anchored by your ischium and your floor. They all attach, as you know, that diaphragm attaches to your ribs, and so does your abdominal muscles. Without getting into specificity, which we often, I think, do too fast, we've got to remind ourselves of the non-specific activity that's required by physiological physics, and that is this mechanical pull of the diaphragm. So here's a slide, an illustration that shows you when the increase in volume lowers your pressure, that means the ribs will move up and out as the diaphragm contracts. That diaphragm, when it pulls, is literally pulling air into your lungs through that physiological state of gaseous exchange inside your lungs. But the mechanical part of the diaphragm's contraction at the same time is actually drawing those ribs out and up. And when those ribs go out and up, you want them to go out and up without losing the power that the diaphragm needs for its attachment sites to be secure. Otherwise, you wouldn't be able to pull in and increase that volume of air that's going into that lung, which is decreasing your overall pressure on the inside of your lung. But the overall pressure on the outside of your body, the outside of the chest wall, on the floor is going up. So when I fill myself up, Jen, with air, I sense the floor. And again, I'd write that down, because if you can't sense the floor, your diaphragm's not pulling in. So I know if someone can't feel the floor, Jen, the first thing I got to do is help their diaphragm do what? Pull, find the floor. Diaphragms find floors, and floors find diaphragms. That's why I wanted to do this webinar series, because in these COVID times, these patients need ground more than anything. Their own ventilatory system is not plugged in. They're getting these ventilatory machines made for them for negative iron lung air pressure producing activity, when their own iron lung, their floor, their iron, isn't working very well because of what we just discussed. So that's really an important part of this discussion this evening. When we decrease the volume in our lungs, the pressure obviously goes up. We get a higher pressure, the ribs fall down, the diaphragm moves up, and the chest wall, the volume of that chest wall decreases. That's when you lift up a leg. That's when you move an arm back behind you. That is a constant exchange of activity that produces either negative pressure, enhances it, or decreases it. So just again, if you look at the blue arrows, things move in and out of a trachea of a windpipe, and now airflow is driven directly by how we operatively control our ability to push concomitantly when we pull. We're all movement specialists, Jan, and I think the words push and pull have a major impact on decisions you're going to make when you choose any activities in life. If you really want to extrapolate good ventilatory breathing activity. Breathing is more than just taking air in and getting it out. Blowing up a balloon doesn't mean you're going to be a good breather. Blowing up your balloon and also in the same time maximizing the balloons inside of you, you got two of them, will make you a much better efficient mechanic. Corresponding negative interpleural pressure that is simultaneously created between the parietal pleura and the visceral pleura pulls that visceral pleura and outside surface of the lungs toward the expanding chest wall. So now the space between the viscera and the parietal pleura is actually decreasing because of, you're pulling things out, but the chest wall is going out, but so is the lungs, they're expanding. Now that lack of air or that negative pressure around that lung is also being lengthened out because the entire chest wall is what? Expanding. So as the entire chest wall expands, the thickness or the distance between the pleura and the viscera is narrowing because all that suction that's created around that lung tissue is being thinned, but pulled and being filtered, if you will, throughout a larger area, a larger region than you would have had if you would have exhaled your air. It's a good illustration of, I'm not going to get into transpulmonary pressure this evening of, the 760 millimeters of, we're not going to get into blood flow and ventilatory activity associated with millimeters of activity of pressure, but we are going to talk about the right side, the atmospheric pressure on the right side of that illustration. If you look at lung, the thoracic wall, the pleural cavity, the visceral pleura, and the parietal pleura, it's a representation that the intra-alveolar pressure changes as that cording or ventilatory activity changes. And again, I look at this slide and I remind everybody that there's this gradients of difference between atmospheric pressure and the pressure inside of your lung. And when you look at the lungs, to be ignorant of what's going on the outside of your body is really not good thinking, because you can breathe inside of a chamber called an iron lung machine. If it pulls your rib cage out, because the wall of the building or the machine is now your new thoracic wall, and the visceral pleura is now the rib cage, you just create negative pressure between the chest wall and the iron lung machine, or the wall that's around us, called atmospheric pressure. Your patient's ability to handle atmospheric pressure, again, depends on whether or not the compliance of that wall is really there or not. Some of us are around people that have very stiff walls around them. They were built by concrete builders, not, vibratory builders. People that believe in wood products or rubber, or trees that move. If you put a concrete wall up and that thoracic wall doesn't move, the pressure on the outside of your body is so high and your compliance is so low that your negative pressure producing capability is not possible. So now you lose awareness of the floor. A large percent of your POTS patients need more compliance and elasticity of their outer chest wall, the outer atmosphere of their body, so they can find the floor. If they don't have that elasticity on the outside of their body, and someone tells them, hey, you don't need you're not lifting concrete every day. You're lifting air every day. Relax. Bend a little bit more. We're going to talk about a technique tonight that's going to allow that chest wall to be more compliant. Then they'll find the floor. I love this picture because, Jen, it says the word atmospheric. You're a movement specialist. I would strongly encourage you to start thinking about that word, atmospheric. What type of atmosphere are you creating for your patient so they can become better ventilatory machines? And you'll do a better job on the outside of their body by creating a better atmospheric program for them on the outside of your body, because you can't get on the inside of their body unless you start working on the outside. And what kinds of techniques would you choose to enable that individual to really do something about the atmospheric pressure they're dealing with on the outside? And that's why I selected this technique tonight we're going to go over. The technique we're going to go over tonight is an atmospheric technique. Negative pleural cavity pressure, or negative pressure, negative pleural pressure, or negative ventilatory pleural pressure is mechanical ventilation, in which negative pressure is generated on the outside of the chest and transmitted to the interior to expand the lungs and allow your air to flow in. That's breathing 101. But it's mechanical and it's ventilatory. Mechanical means the ribs are pulling out, and it's ventilatory means that you're pushing your pleural, your visceral pleural out. So it's ventilatory and it's mechanical ventilation. This illustration demonstrates that when the chest wall plus the rib cage move, your intrapleural space is going to decrease, the lung is going to fill up. And if you take a note of that picture where it says the diaphragm is that red thing on the bottom, it looks like a floor, doesn't it? I know that individual who has now contracted their two diaphragms has just found that floor. And when you get your handouts, you might want to write on there, that diaphragm knows that foot that they're standing on to breathe has a flat surface underneath that foot. It's called the floor. So when that diaphragm contracts, you're on that floor. Now, when you are in a relaxed state, the negative pleural pressure decreases, and your breathing mechanism looks a lot different. The chest wall's not as wide, obviously. With positive pressure ventilation, With positive pressure ventilation, the transpulmonary pressure is increased by making the alveolar pressure more positive. So when you see these positive ventilators assist people to breathe, they're putting positive pressure directly into the lung. That's in contrast with negative pressure ventilation, the transpulmonary pressure increased by making the pleural pressure more negative. Either way, air that's being pulled into the lungs as a result of the increase in negative pleural cavity pressure also assists with this chest wall expansion. By pushing, either way, whether it's positive or negative ventilatory assistance, you're still pushing, by pushing the chest wall out in those areas where the negative pleural cavity pressure is not as high because of low chest wall compliance. We have parts of our lung that have lower compliance than other parts of the lung because the position you put your bodies in over time. Habitually, we see and we're built around this asymmetry. We have less compliance in our posterior mediastinum on our left side than we do on our right side. We have less compliance in our right lateral chest wall than we do on our left side. So we're built under an uneven chest wall. Most people think when they look at the Britannica Encyclopedia and they look at a chest wall, they assume that the pleural cavity is the same around the entire chest and body. It's not. So we got to be mindful of that. So that chest wall could be more or less pliable depending upon the position it's in, or malposition it's in, or twisted or tighter position it might be in. One of the best ways to maximize balance, proportional, and better symmetrical circumferential levels of negative pleural cavity pressure is to enhance the push from the ground push up to stabilize and support the contraction of the two asymmetrical diaphragms for pull. The better one can generate push from the hamstrings, glutes. The better one can generate push from the hamstrings, glutes, and abdominals. The better one can maximize bilateral balanced negative pleural chest pressure and optimize that lung ventilation for perfusion. This is an old slide. We found it, we dug it out today. But what you see is someone standing that's probably going to have good ventilatory perfusion because they've maximized their negative pleural capability by opposition to the opposition that the diaphragm needs for good expansion. And that opposition is from those glutes and the hamstrings and the abdominal muscles, as we already talked about. I believe lungs, Jen, kind of have personalities and behavior. I thought about before I put this down. I don't know what you thought about when you typed it up, Jen. But I think of muscles sometimes as people, and I think lungs have personalities. There's two of them. They're twins down there in your thorax. There's our lungs. If they could talk, I believe they would tell you that they like these three things for proficiency. My lungs could talk tonight. They would say, here are the three things I like. I think if your lungs could talk to you, Beth, they'd say, here are the three things in your life that they like, okay? Here's the first one. Evenly distributed negative pressure that places them in an ideal position that give them the best ability to evenly expand both sides of their viscera pleura. So the word evenly, Beth, was said twice. I'd underline that. See you taking notes. So underline the word evenly twice, because that would be what I think your lung's going to say to you. Put me in an operational mode of activity where you're going to give me an even possibility, potential, performance on both sides. I want both sides to kind of balance this out. There's two of us. Number two, I'd want ground-based push. If I was talking to you as a lung, I'd say, please give me ground-based push. Otherwise, I got to work my butt off, literally my butt, because it's not the butt I should be working. You should be working if you're a butt. But I got to literally work harder. I got to do everything I can to not only fill you full of air so you can move around, but I got to keep that activity going on for way too much time. I got to contract way too much. I've got to get this in range of expansion there all the time because my butt, the butt that I should be using called the glutes down there aren't working. So please, if I had one choice, please, a couple choices, three choices, I would want a ground under me for push. I want somebody to lift that will, lift my body up that I'm attached to enable me to provide the support for the shoulder blade that's resting on me. I got two of them on me. One on me and there's one on the other side, my twin. So my arm for forward reach and overhead activity that further assists with development of negative pleural pressure. You should all be mindful, Scott, you should be mindful that when you raise your arm up, you need your chest wall to expand. And so when you look at arm reach and arm development, negative pleural pressure has to be there for shoulder mechanics. You can't blow your nose. You can't put your facial mask on. You can't lift up. You can't clean the wax out of your ear without negative pleural pressure. So I would say, please give me ground-based push, and please allow me to chest expand. So my shoulder surface support is maximized because without negative pleural pressure, I got a little I can do for that big shoulder blade. I'm trying to do everything I can to be compliant underneath of it, but I'm struggling because I don't have that push from below. And the third thing I would ask for, clockwise rotation and alternate counterclockwise rotation for the perfusion I'm responsible for, because blood has to exchange gas, and that has to be swished around and swashed around and moved from side to side, as we talked in the first series of this webinar series, first night. I got to move. I got to get things to move. I'm responsible for that perfusion and ventilation in my lowest lobes of my lungs that I own. So those would be the three things I'd want. Lungs are like twins. They have separate identities and behaviors because they are not identical twins. There's none of you that have identical twins inside your chest wall. They're two different people. They have two different personalities. They really are not like-minded either. One is more hypocapnia-minded and one's more hypercapnia-minded. So I think next week's discussion, talk about mindedness, carbon dioxide mindedness. The right lung is more like a weightlifter and a construction worker in my mind, and an assembly line worker or a mechanical worker, a force producer, a mover. It's not a shaker, because that's the other lung. It's more of a static position minded lung. It's responsible for your posture. It's responsible for control. It wants the floor. It demands the floor. It has the floor. It can't work without the floor. It doesn't want it. It doesn't operate without it. It's not even a question. When I contract, I got the floor. That's your right lung. That's your right side of your body. The left lung is more like a singer, an actor, an artist, a painter, a dancer, a mover, a flute player, a drummer, a resonance maker. It doesn't need the floor. It's got resonance. It vibrates. It's a shaker. It's a mover. It gives you the opportunity to think outside the box. It's a more like a dynamic-minded individual, always will be, and is always willing to pass off the baton to the right lung when some force is needed, when some stress is needed. It's willing to pass that off. The two are a good partner. They marry the right people. They were put together for the right reasons. I'm not sure what's going on with that. Thank you, Jen. It also is the lung that needs more ground, the left one, and overhead push to keep the left diaphragm leaflet more stable. It needs more help when it's being asked to work. It needs more support, more security for sufficient dynamic negative pleural cavity pressure. It's much easier to produce negative pleural cavity pressure on the right than it is the lung, than it is on the left, because that lung is a little less secure. I have a problem with my slide changer. One activity that will assist in developing this cooperative lower ground foot-based work and upper ground shoulder-based push for left negative pleural cavity enhancement, because that's really where we want more left negative pleural cavity enhancement. Breathing is this thing called the standing support left glute push technique. And before we get into it, Jan, I'm going to flip this around and remind everybody that tonight we're going to talk a little more about this technique that has this ground under this lady's foot. But I thought it was important before we get into it tonight to remind everybody, put a little, you don't have this in your handout material, and I think, Jen, if you could, the camera's on it. I went ahead and took right before we started this evening, I took my black color, and the black is representative of a thorax at rest. So there's always a little bit bigger dome on the right side of your body, and we just went over the need for us to get more negative pleural pressure as much as we can possibly get on the left side of our body, because we do pick up our right leg once in a while, and we do raise our left arm in the air once in a while, which means we need the left floor. We need it badly. Now, God made a beautiful animal here. It's a wonderful, wonderful machine. It's yin and yang. It's up and down. It's side to side. As I said, there's a personality. Thank God we're not perfectly symmetrical here. That's called wobble. That's a sinusoidal wobble. That means your body's going to constantly coil and recoil. It means you're going to counter-rotate and rotate with every contraction you make. Every time you swing an arm, we're built around that diaphragm's unevenness. And then when that chest wall starts to open up, when you take a breath of air in, and you have abs, you have costal chondral regions of your lungs, because the chest wall has costal borders to it. And when the abs keep those costal borders in a good position, when the diaphragm contracts, that wonderful chest wall will start to expand and open up. Ribs will come up in the front as they expand evenly around the body, because the abdominal walls is going to keep that request we had as a lung. I want even negative pleural pressure. So the more abdominal contraction we have universally, the more evenness you're going to find when that thorax is expanded by that contracting diaphragm. So when that green, representative of the diaphragm, you take a breath of air in, descends, everything else is going to pull apart. That chest is pulling that lung open. It's being pulled out. Now, that's with opposition from glutes, hamstrings, and abs. If you don't have glutes, hamstrings, and abs, you'll inhale, but you won't have a push. You have no surface. So now what you're doing is you're taking a breath in, and now the diaphragm descended too far. It went down too far as the pelvis anteriorly rotated, and things went through an inlet and in wrong places and an outlet of your pelvic floor diaphragm. And that rib cage now is going to be more narrow, more condensed, more linear. It didn't expand as much as the green one did because there's no opposition. And the power on this person is now going to be generated by accessory muscles to get that chest wall to open up more, to lift more from an anterior neck set of muscles. Big one was the scalenes and sternocleidomastoid. I think you guys got the picture. So the red down here is not really a cool thing. The technique we're going to look at is going to minimize this red and maximize this green. And we're going to maximize that green by selecting a side to maximize the most off of. That's the left floor. So we're going to do those three things that we talked about in that handout. Those three things that the lungs want. These twins want this activity really bad. They want to bias activity a little bit when you take a breath of air in. And that's what this technique does. It biases that ground a little bit. It's one of my favorite techniques. I think it's probably one of the last techniques we put together for the Institute's CDs. So, Jen, what we're going to do is we'll pull it up. I think they've got this in their handout. Jen, did I do okay there? Is there anything that you want me to go over? So, Let's go through this technique tonight. You have two parts of this handout. The first part, Jen, and I'm going to do this with all the techniques for this chest wall series, is it just talks about the reasoning behind it. So this next 5-10 minutes, we're going to talk about the reasoning for the technique and what it really is all about. I kind of introduced it to you here a little bit. And then if you turn the page over, and I assume they have that, right?
This is on the blog. I will post this full document to our website as well. But this was posted to our blog a couple weeks ago when we first introduced the technique. So yeah, it's on our website, but I will put it directly next to this recording tomorrow.
And the second page is more additional comments that really are there for the movement specialist. So when you look at it, you're going to get a little more technical information. And then you finally got the technique that has, I think, about, 6 or 7 steps to it, 5 steps to it. I like this gold standard technique. I like this technique because it summarizes this evening very well in my mind. Everything we said this evening is summarized by this technique. This is a standing technique. I would put some good shoes on people. I get some counter support on their heels. I have some support in their arch. I make sure that they have a toe box that can spread out because the diaphragm really is hungry for a wide forefoot. That'll allow them to easily spread out, sense it, and their foot should be directly underneath of them. You also need to push a table or something that's next to a wall so they don't push the table forward and fall on their face when they do this. I think you guys can figure that out, but I do make a point to remind you, if you have something like a table or something that they can push on, like a plinth or a cot or a bed or whatever it might be, whatever it might be, the secureness of that, if it's moving around, this is not a good technique. So if it's a little unstable, that diaphragm's going to know it. And I guess I could say the word trust me, but they got to trust that piece of equipment called a piece of furniture or whatever you're going to use. So make sure it is stable, because if it's moving a little bit, this knows it. This chest wall knows it. And your twins will talk about it. And that left twin's going to say to their right twin, I'm out of the game. This is too shaky for me. So just keep that in mind. These two diaphragms talk to each other. So what I would do is make sure, number one, is you get some good shoes on them for stability on the floor. That's where it starts with. They got to have a stable foot. And number two is their hands need a pair of shoes. And their hands are going to use the furniture just like the foot is using the shoe. So I'm being mindful all the time that there's no difference between what you put your hands on and what the feet are in. So make sure that the shoes that they're pushing on, called a table, is secure. I'm asking you to do that 3 times. Make a note of that 3 times. Otherwise, this technique is not going to work. This PRI technique is designed to place a person in a Valsalva-like maneuver position between the states of exhalation and inhalation phases without blowing up a balloon. So we're not even going to put a balloon in their mouth for this technique. In fact, it's better if you didn't. And hold the expelled air out while they're pinching off their nose. Well, they won't even have to pinch off their nose because they're going to be holding their breath. To hold them up with an arm that's holding them up on a floor that's holding them up. If you could write the word holding and then put the word breathing next to it, cross out the word breathing, because when you hold, I didn't mean breathing, balloon. Write the word holding and write the word balloon. And then if you hold something, you won't need to blow up that balloon, because that Valsalva maneuver is going to provide the opposition you need for negative pleural pressure production. In this technique, the force applied to the table and the floor will allow the tongue and mouth to close off the airway and properly use the abdominal muscles and the diaphragm to exhale and inhale without engaging the neck or back under moderate pressure created by closing off the pharynx with the pharyngeal muscle and the larynx, trachea, with the tongue muscle. So you don't even have to tell your patient what to do here when you read these 6 steps. If you put them in a position and they're holding themselves up, as you see in that diagram, they're going to be doing all this with their pharynx and their larynx without you saying anything to them. So it's it's a great feed forward technique for negative pleural ventilatory pressure. This voluntary control of the abdomen is maintained during the entire technique without having to think about how to hold the contraction of the abdominal area during both phases of the respiratory cycle. So I don't have to tell them, Jen, don't let go, don't let go. They can't let go. They're in a prone-like bent over position. I think it was week 2, we looked at that postural drainage position. Their ventilatory activity and perfusion went sky high in that position at this point without doing anything more. Just get in that position with shoes on your hands and a table underneath your foot called the floor of the table. It is a wonderful way to teach someone how to inhale with good opposition to the diaphragm so that effectiveness on the opening of the mid and lower chest wall is maximized. As a subconscious effort, you don't have to think about this too hard, is being maintained by the abdomen stabilization. That is minimal at that point. Those abdomen muscles don't have to be cued. They know what to do. They know exactly what to do. You don't have to tell them to do anything. They'll do it in this position. The support of the upper extremities offers you the stability too that's offered by the stable and the countertop that we ask you to make sure was stable. Allows one to lift the right leg up and the right foot off the floor as the left glutes push the body forward to further stabilize the lower trunk and pelvis as the right hip is raised up. You want to make a little note here. Your left lung, the left twin, is now a static performer. It's a weightlifter. It's a singer that became a weightlifter. It's a painter that became, a crate carrier. It's a different set of activities by picking up that right leg. And in that position, the evenness to the negative pleural ventilatory cavity that you want to create has just been brought about. The biasness inside your chest wall has been reduced by just that simple procedure of that woman picking up that right foot, or you picking up that right foot. And I encourage you to try it this evening. This activity co-activates more integrative assistance from the right hip flexors, the right lower trapezius muscles, and the long head of the triceps, as well as your left abdominal wall. For PRI people out there watching tonight, that all should make a lot of sense to you. You dedicate your life to these muscles if you do any PRI type of work. That's the PRI life, that is. There we go, Jen. When all said and done, the tension and internal pressure created by the lengthened anterior shoulder, because your shoulder's in the air, literally, and hip flexors enables one to breathe with the diaphragm under high compliance, which means that chest is now expanding. That means its compliance has never been higher because of this position. Look where the arms are. Look where the feet. You took one extremity away. You're down to 3. And when you take that right foot off the floor, your compliance now just maximized through the chest wall. And the forgiveness of the lateral and posterior chest wall tension is now going to, there'll be ability to expand those regions easier. This technique is therefore a great technique because the lateral, posterior, apical, and base surfaces, as we talked about first webinar session, of both lungs can expand easily upon diaphragmatic contraction, secondary to chest wall compliance and the gravitational force displaced on the abdominal contents. So right now, when you look at her breathing, her abdominal contents are being reorganized. Her pelvic floor is stabilizing her, and she's getting all the necessary pressure from those areas that I just mentioned to enhance this pleural negative expansion, this pleural negative pressure, and to then override any atmospheric constraint put on her. So her body just became a machine at that point. She'll stand back up and feel empowered because now she's using the atmospheric pressure around her to empower herself immediately after she leaves this position. She's balancing her internal pressure with the atmospheric pressure around her, so the few pounds that this particular person weighs is meaningful. She feels herself. She's weighted down for her to lift weight around her. Space is now easily adapted to because it's meaningful. That's atmospheric pressure. The internal organs fall anteriorly and off the front of the thorax and lumbar spine. Desirable, especially when you want to move fluid. Drainage will occur as well as perfusion in the lower lobes of your lung. It's also an excellent postural drainage technique for the posterior lobes to the mid-lower lungs, preceding the standing positional induced coughing that more than likely is going to happen when you stand up. They'll start to cough. A lot of these patients will start to hack things up because of this drainage. These are velar sacs. They're now loving this. The twins are happy down there. They actually get along for a change. They look at each other now and they're more similar. They act the same. They look the same. They react the same. They may even be close to becoming identical in this particular position. So additional comments about anything I just said that follow the title and pictorial examples can be found on the second part of this handout on the back page with more reasoning and procedural steps. I'm going to have Jen take a minute, and Jen, you want to talk about what's on the bottom of that?
So that's just a link to the blog, but like I said, tomorrow when I post the recording, I will go ahead and post this full handout of the technique as well as Ron's breakdown of this clinical reasoning and each steps on our webinars page as well. So it'll be in a couple of different locations on our website.
Is the summary, did I put a summary slide on here? Do you know? This doggone thing. There we go. In summary, this is an optimal position technique for the diaphragm to be in for costal or mid to lower rib expansion upon contraction. It's a wonderful optimal positional technique. And it's also a great positional technique for one to sense, and I would underline, circle that word, it's on the second page, the abdomen. Sense the abdomen, lift the abdominal cavity up. When the abdomen lifts the abdominal cavity up, your pleural cavity is expanding. That's a 1-to-1 ratio. Abdominal cavities are raised up in this position, expand pleural cavities. If you want to enhance negative pleural pressure, you want to reduce positive pleural pressure, think of this position, think of this activity. This is a postural drainage program because you're using gravity. And feel how your own body reacts to your weight now. Your body's weight will be truly sensed. You will feel weight through 4 appendages. You're walking on a scale now that's now under both sets of your arms and legs. You have a scale under your feet that you're pushing a table with, and the hands that you're standing on. It's the same thing. Your brain doesn't know what's what. It just feels weight. And that's optimal weight because now your diaphragm's influencing the chest wall mechanics for ideal ventilation when it contracts. The best chest mover you have is not your arms. It's not your chest. It's not the intercostals. The best chest ventilatory mechanical programming machine you have is your diaphragm. Your diaphragm moves your chest wall. Nothing else does. Your diaphragm and atmospheric pressure moves your chest wall. If you're going to be a mechanical-minded, muscle-minded person, you probably ought to just back off a little bit and remember that muscles do not move your chest wall. They can't. There's no surface that those muscles can attach to if you don't have pressure and a diaphragm that's contracting at the same time with that pressure. Diaphragm muscles are diaphragm muscles are muscles. But those muscles, the diaphragm, when they contract, they have 2 of them. They have 2 twins above them. And as a result of their contraction, they require each other to contract. If one diaphragm contracts and the other one doesn't contract, you can't breathe. And so that's why they have separate innervations. They have innervation from one side. I mean, both of them get the same innervation, but if one happens to go dormant, the other one's going to help out with it. It's a wonderful phrenic system. So it's a wonderful thing to talk about. Movement and ventilatory perfusion from negative pleural pressure is done through a postural muscle, and that postural muscle, therefore, is your diaphragm. I think that's a pretty good slide there. I want to thank you for that. Before we go, I'm going to have Jen just take a minute Or do you want to answer questions? I was going to read this thing and comment on a couple of things, but if you want, we can take questions tonight.
Take a couple questions.
Okay.
Just specific to this technique. If you have a question specific about this technique or this discussion and how it relates to this technique, feel free to use the little chat feature at the bottom, and you can either just say, hey, I have a question, and I'll find you and unmute you, or you can type out your question and I will just read it to Ron here. So yeah, let's take a couple questions because they'll have this full document.
Since we won't read it, I just want to remind you that there's one word on that. There's 5 steps. And if you look at the 3rd step, shift your left hip back. And that's the only thing I really want to comment on. When you look at the handout material, it says shift your left hip back. Don't forget that, because that's as big as finding a secure surface to put your hands on and wearing good shoes. Those 3 things: secure surface to stand on, secure surface to push on, and shift your left hip back. No questions?
I don't have any questions yet.
Okay.
Any questions? Even if you just want to say, hey, I have a question. Jennifer Bullock has a question. You're muted, Jen.
Okay. I have a patient that is bilateral thoracic outlet syndrome. And I didn't know if this exercise could be modified slightly, because I don't even think she's going to be able to get her arms up. Could I put her in a little lower position?
Sure. Jennifer, anytime you put the arms out, the benefit of this program goes up. Okay, just keep that in mind. So, you know, everybody has issues. This may not be the best technique for that patient, by the way. There's 10 others coming up in the next few weeks. This is the first one. But it's the most ideal position, to generate NPV, the negative. It's the most ideal. Now, when the arms start going below the shoulders, that's a different technique. And that'll be in our very last week of the webinar. We got about 2 or 3 in that. And we'll talk about that. That's what we're talking about right now. So I'm going to answer your question by telling you, when the arms go under you, you're dealing more with carbon dioxide movement. You're dealing more with people that are having a difficult time breathing because they can't get their arm above their head. You just told me that. And so anything you can do to start directing that activity, you direct that activity, which is other techniques you might want to consider. And that would be a couple things. You know, one of those things, the first thing I would do is start working with the knees. Start working with lower appendages. Because if you start working with the knees, you might be surprised that as they work with this, their arms are going to actually go above their shoulders without them even knowing it. So it's a polyarticular chain discussion, what we're having. But you're right, if they can't get their hands at least above their shoulders in this technique does not become as effective. But that's why I chose it. It's a no-brainer. It's just, you know, so you can adapt it, you can change it, but if the arms go below the shoulder, it's not going to do everything we talked about this evening. That makes sense. You just got to do the best you can, and there's other things coming up that we should probably look at first.
Okay.
Great question, Jennifer. It's good seeing you this evening. Look great.
Okay, another question from Kelly. Once the patient has a good management of this supported table with this technique, would it be appropriate to eventually progress to upper extremities on an unstable surface, such as cyclist on handlebars?
Oh, sure. Sure. I mean, Kelly? Sure, absolutely. There isn't anybody that's going to not get something out of this technique, which is why it's there. But it's definitely not an aerobic technique. This is a pre-aerobic technique. This is an end aerobic technique. Aerobics challenge negative pleural cavities. Aerobics challenge it, especially if you're doing activities where your arms don't get above your head, or you don't get off of one foot, called the right one, once in a while. So aerobics are speed. Just remember, aerobics, speed, usually. Aerobics, speed. This is more static. There's no movement going on here other than breathing. This is drawing something in slowly. It says, take a deep breath in. This is filtering slowly to expand something. Now, you keep the arms moving in any aerobic activity you do. that would be a wonderful thing to do to follow up with this. But in the spirit of the context of the discussion tonight, I know a lot of people that do great things with aerobics, and they get done and they're out of breath because they start off with too much inside of them. They didn't get it out. So this is a pre-aerobic program for compliance that was built off of anti-gravitational opposition muscles for a diaphragm to become a more aerobic machine, mechanical machine, and you aren't going to get a lot of mechanical heart rate and blood pressure built up with this type of activity. However, you're going to get more into a good zone of aerobic activity because of this activity that preceded it, because you're increasing your ventilatory capability and you're increasing your compliance and your perfusion. So you're going to do faster, better, more work in a quicker way, by preceding that activity with something like this. That's why you'll see people at the end of a race or some, Jen, you watch these runners. I don't know what they're called, but they look like they're doing something like that. And you'll see them go to a tree or a bench and they'll spread out. And the first thing they're doing, they're panting and they're out of their breath. They're trying to renegotiate pleural pressure. Any of you have been out of breath, you know what I'm talking about. So I love the question, but I hope I answered it for you, Kelly.
Mark asked, how strong is the push from the left foot into the ground?
The push, if you push too hard, you'll start to extend your back. You want to keep your back slightly rounded, as parallel with the floor as you can, but slightly rounded. And you don't have to work hard at anything, Mark. All you got to do is pick up your right foot and use your right hand, because the arm, the appendage is going to work hard is the right arm. And that's what's beautiful about this technique. And if you read the second page, you'll understand why it's beautiful. Because now you got a right arm and a left leg that are communicating with some lungs that are now unbiased. So, Mark, good question. Here's what you should think about. Floor's not going to be an issue. The pressure on the floor on the left side is going to go up depending on how well you push in that table with that right arm. Because if that right arm isn't pushing, you're not going to feel anything on that left floor. You won't even know it's there. But the minute that right arm is pushing, you just put pressure between your right arm, and it has to go through the current of resonance. The electrical bolt that came out of the sky just hit your body through your right fingertip and went out your left heel. That's what you want. Left heel, right fingertips. And so if that left heel's down and your right hand's pushing to hold you up to pick up that right leg, you're automatically going to start breathing on your own with the correct diaphragmatic activity to stabilize you as you shudder. Because every time you move now, the floor is going to vibrate, which means pressure through the arm on the right and the foot on the left is going to go up and down every time you take a breath in. So Mark, to help you with your answer, your pressure on the left foot is not going to be stable. If you feel a lot of pressure on that left foot, you're not breathing. But if you breathe, every time I take a breath of air in, that floor is going to come up and that push is going to be there. And then when I blow out that air, I don't even know I'm on my left foot. Something happened. Where did it go? Well, that's your left hand holding you up with your abdominal wall holding you up at the same time. Now you just transferred your weight to your left hand and your abdominal contents. It's a wonderful machine that works that way, called forward locomotor movement. Check it out. That's how you work. So Mark, that pressure should not have to be worked at. If anything, I'd encourage you, Mark, to think about your right hand.
Okay, a couple more questions. I'm getting lots of questions now, but we'll answer just a couple more here tonight. Thoughts on using this as a post-aerobic activity technique in athletics, more so than other positions discussed in coursework? What would your thoughts be on kind of a post-run or post-athletic?
Who asked that question? It's a good question.
Lyle,
here's the issue. Lyle, every one of the techniques I put together for this institute has this activity in it. What if I told you that? Every single one. It's just that I'm just pulling out this one activity to tell you that it's a good one to think about and break down. But every time you see an activity in PRI where it says, take a deep breath in, I want you to think about this conversation we're having right now. So Yes, yes, and yes. It would, you know, I'm not even sure, you know, how to answer it. This is a technique that will help explain all other techniques and all other techniques in all other positions. Because of all other techniques, we have maximized the left leaflet's position. So this technique looks like it's unique, and it is unique because you don't have to think about a thing. You picked 2 pairs of shoes. You picked a pair of shoes to put on your hands, and you picked a pair of shoes to put on your feet. But all other techniques are thinking about the same thing. You just don't see the shoes. You don't see the stability, but it's there. I would encourage you to take this technique, and I'd prepare for all other techniques, which is why it's number 1. I said, Jen, this will be our first one, because this is the one that I think will help you appreciate all the other techniques in terms of negative pleural pressure. And then last, Lyle, the thing I love about your question is you liked what you heard tonight because now you're thinking, could I use this in exchange for other techniques? Well, the answer is absolutely yes. In fact, if there's one technique I'm going to ask all of you to do tonight before you go to bed, brush your teeth, say your prayers, go to your bed, make sure it's against the wall, and please do this. And I think you'll appreciate the power of these twins. And I like to go to bed with both my twins getting along. Otherwise, it's called sleep apnea. Someone's going to put a CPAP on you because you didn't understand what Lyle just asked. So yes, it's a pretty good, important concept that's in all techniques, because all PRI techniques are trying to make the pleural cavities more even. So I appreciate that question, because then I could answer it the way I did. Let's take one more.
Yep.
We'll call it evening.
Since this is specific to the technique there, Ron has it in front of him. This ties 2 people's questions in, but it says, in the picture, it appears the left toe is off the ground. Is this intended to capture the early stance phase, or is it intended that the left toe and the entire left foot can sense the ground?
Yeah. I see the picture, and I don't see the left toe, the heel coming off the ground. Maybe
Toe coming off the ground, he said.
on which side? The left side?
Yeah, I don't know. I don't have it.
Well, let me answer the question. That foot on that left side is in the very same position on all 3. So yeah, there's no.
And do you want?
And can I just real quickly, who asked that question?
Gregory.
Gregory, thank you. Don't look at pictures and read into the pictures, Gregory. I'm just trying to help you. Look at the 5 steps and read into them, okay? And because we have these people calling all the time, and then years Jen's worked here with just good questions, because they're trying to look at everything where the picture's trying to indicate on the right way and the wrong way to do. But I really appreciate the question. The toe stays on the ground, the heel stays on the ground. I would read into why are those 5 steps written the way they are. And if you can simultaneously read that and then think about what that person might be experiencing, you'll get more out of that technique. Most of these techniques you really can't mess up too badly if you just read the steppage, if you will, the steps associated with it. But I love your question, and again, be mindful of the fact that that left foot, if you remember how we started this conversation, the very first slide on this conversation was wide toe box.
It has to spread as you do this technique.
Diaphragms love wide toe boxes. Your posterior mediastinoms love all 5 toes. Your pleura loves to allow the chest wall to relax through opposition provided by a floor on those 5 toes. I enjoyed this evening very much, everybody. Jen, I'm going to call it. You guys were awesome, and thanks for coming and listening to these webinars. Jen, I'll let you finish up. Is there anything else you want to say this evening about?
Oh, absolutely. Yes, thank you. I'm
Yeah, it was
answering a couple
great.
other questions here as we finish up, because we didn't get a chance to answer all of them on the webinar. But we will have more discussion. There was someone asked about application to people in the ICU or acute care. We'll keep kind of touching on this. This technique really isn't probably something you can do with someone that's on the ventilator. but keeping in mind the concepts of this position and what this position is doing for those people that are in acute care or in a ventilator settings is something that can definitely be applicable.
For those people that didn't get their questions answered now, Jen, we're going to show you techniques where people are doing the same thing, hands on walls, hands on floors, and they don't have to be pushing this hard at all. So be mindful of that. And the fact is, this is just a great technique for all of you sitting there this evening, sitting there or standing there, should be able to do this technique. And it's a great way to start a series on, I think we got 10 or 11 techniques. So it's a great way to start this discussion, because a lot of the theme in this, a lot of metaphor in this, the twins, is going to come up again. And I just want to make sure we're all on the same page if you're following this. Next week, we're going to talk about regulating lung carbon. We're going to talk about green earth, carbon dioxide, why we need it. It's got a negative rap in the papers. You know, if you look and, you know, look, you know, what's that?
Mask wearers.
Yeah. So we're going to talk about mask wearers a little bit. We're going to talk about carbon dioxide through postural in-range deep breathing. Postural in-range deep breathing. Have a good week. We'll see you next week. Thanks for attending. It's great to have you on our chat room.